good morning, Professor Abel. Thank you so much for the wonderful introduction. My name is Yong YG Lee. I'm an assistant professor in the Department of Social Work and Social Administration. I also want to thank the research team for giving me this wonderful opportunity to share my research today. I also want to thank every one of you for being here this morning. Really excited to present to you my research, share my research with you. So for those of you who don't know, I am a behavioral HIV researcher, which means I study patterns and predictors of behaviors associated with HIV risk or protection, ultimately to inform prevention efforts. My research primarily centers on the experiences of sexual gender expansive individuals who unfortunately continue to be disproportionately affected by HIV. I have previously worked on HIV prevention trials in the US and in Kazakhstan, and I currently lead a behavioral HIV survey in Indonesia. So today I'm very excited to share with you findings from the latest published study that my colleagues in Kazakhstan and I worked on. And this study examined social impacts of research participation among sexual gender expansive individuals enrolled in an HIV prevention trial in Kazakhstan. I hope that my presentation today will provide some insights, exciting insights, perhaps provoke some ideas and discussions regarding conducting human subjects research, especially with vulnerable populations. Okay, so a little bit of background information about HIV in Kazakhstan. As of 2023, the rate of HIV prevalence among 15 to 49-year-olds in the general population was 0.3%. And there's an upward trend, and the rates of HIV have been increasing in Kazakhstan. Just as a reference, the rate of HIV prevalence in the general population in Hong Kong is 0.1%, so it's a little bit higher in Kazakhstan. But both rates are substantially lower than the global rates, which is was around, I'm forgetting which one. Sorry, I need to get back to you on that. So HIV across the world, across the regions, have disproportionately affected certain key population groups, including men who have sex with men, or MSM, as I will refer to them in this presentation. In Kazakhstan, the rate of HIV prevalence among men who have sex with men was 8.8% as of 2023. And as you can see, it is substantially higher than the prevalence rate in the general population, but also the highest among the key populations, right? So the SW, I don't know if I can point, so that's sex workers, MSM, people who inject drugs, transgender folks, and prisoners, which is quite striking. And it also indicates an urgent need for HIV prevention efforts in these key populations, including MSM. So there have been reports of widespread stigma against sexual gender expansive individuals and people living with HIV in Kazakhstan. And as many of us know, stigma can pose significant barriers to accessing healthcare services, including HIV care, right? And indeed, our prior studies have suggested that multiple forms of stigma exist and also exist to serve as significant barriers to HIV testing and treatment among men who have sex with men, as well as transgender folks who have sex with men in Kazakhstan. Moreover, persistent stigma can also pose practical and ethical challenges for conducting research that is needed, urgently needed in the local context. So for instance, participating in HIV research can elicit presumption of HIV status or sexual orientation, which can in turn instigate even more negative attitudes and actions towards participants. In addition, unanticipated adverse events, right, like confidentiality breach can happen and could exacerbate psychosocial vulnerability among participants. So these effects of research participation, whether they are anticipated or unanticipated, these effects on personal relationships and social status, health, and other life domains have been conceptualized as social impacts. And adverse and negative social impacts are negative social impacts. So the repercussions of stigma that I had just discussed would be examples of negative social impacts, or NSIs, also better known as risks, right? At the same time, positive social impacts, or PSIs, or benefits of research participation can also be realized through research participation. Assessment of NSIs and PSIs is central to determining ethical acceptability, right? So just by show of hands, who has conducted human subjects research before? Okay, wow, most of you, if not all of you. That's wonderful. Okay, so for those of us who conduct human subjects research, we as researchers and also ethics committee members know and are tasked with ensuring that risks of research participation are reasonable in relation to anticipated benefits, right? So in the interest of time, I am actually going to skip the next exercise, which is going to be sort of interactive and poll, but I'm still going to walk you through some prompts for reflection. So think about human subjects research that you are familiar with, right? And now think about the potential risks and benefits that are involved, right? And these are, maybe you have come up with a very exhaustive list, or maybe they're short. So what are you also reflecting on? So who determines risks and benefits, right? And also think about what might the participants actually say or perceive or experience as a result of being involved in your research project. So as a principal investigator or a research assistant, you may have been told by a participant how much they have learned about the topic of your research just by simply being involved in your research project. Unfortunately, such feedback is not often systematically assessed or even seriously considered in determining ethical acceptability. In HIV research, participants across multiple studies assessing social impacts have reported PSIs, or positive social impacts, at substantially higher rates than NSIs. Despite their prevalence, positive social impacts are often overlooked in regulatory practices. Perhaps researchers are preoccupied with identifying and mitigating risks, right? And that's not a bad thing to do. In fact, it's actually a very important step in research. However, it also may be incomplete. Dismissing and downplaying PSIs can not only contradict participant experiences, but dismissing PSIs can also unreasonably portray research participation as being all risk and no gain. So this calls for a systematic assessment of social impacts of research participation, one, to ensure safety and comfort of research participation, but two, to promote a balanced approach for evaluating risk and benefits of research participation. So to expand on the social impact scholarship, my colleagues and I set out to assess the overall incidence of social impacts of research participation among a sample of sexual and gender expansive individuals enrolled in an HIV prevention trial in Kazakhstan. We also secondarily aim to identify socio-demographic and behavioral correlates of social impacts in this study. But for the purposes of this presentation, I will only focus on the first objective. If you are interested, and I know you are, I invite you to read the study that is currently in press and will be published very soon. Okay, so the PARENT study was a stepwatch clinical trial of an HIV preventive intervention for MSM, men who have sex with men, and transgender folks who have sex with men, or TSM, in Kazakhstan across 3 different cities, Almaty, Astana, and Shymkent. Participants who are enrolling in the trial were invited to undergo an intervention called Peer Reach and Influencer-Driven Engagement in HIV Care Continuum, or PRIDE in HIV Care for short, which was a crowdsourcing and social marketing and social network-based intervention for increasing the number of MSM and TSM in the HIV care continuum. Participants were recruited through venue-based and snowball sampling methods. The inclusion criteria included being 18 years or older, identifying as men at any time, or being assigned male sex at birth, reporting consensual sex with another man in the past 12 months, reporting illicit drug use and heavy alcohol use in the past 90 days, and residence in any study city, or any of the study cities. Throughout the trial, we conducted robust community engagement to ensure safety and comfort of research participation. So, for example, we conducted site visits to potential recruitment venues. One, to gain access to the sites, but two, to understand better the characteristics or considerations about coming in contact with our potential participants, especially considering the context of high stigma against these folks, right? So in another instance, we have been informed by community members that the terminology that is often used in this sort of research, sexual gender minority, carries a derogatory connotation in the local context. So we opted not to use that term, instead using sexual gender expansive individuals, right? Additionally, we implemented safety plans and staff training for risk mitigation. And finally, we monitored social impacts during the trial. Here's a table to help visualize the study design and timeline a little bit more easily. The yellow cells represent pre-implementation period, and blue represents implementation period. And if you can see, this sort of human figure indicates initial contact with the participants, and the dots, this black colored in dots, represent the visits that were made by the participants. The first dot represents baseline visit, and the subsequent ones represent follow-up visits. And participants completed a structured behavior survey at each visit. And as you can see from this figure, participants who enrolled in the trial earlier had more follow-up visits scheduled throughout the trial compared with those who enrolled in the trial later or towards the end of the trial, right? So they had fewer visits. In the trial, 982 participants were screened. Of them, 629 were baselined, and of them, 579 unique participants were retained for at least one follow-up visit, for a total of 2,648 visits during the 36-month period. Social impact assessment impacts were assessed using questionnaires that have been adapted from prior research. In this study, the social impact assessment questionnaire was divided into two subsets, the NSI subset and PSI subset of questions. And for each subset, the items asked, has any specific NSI or PSI incident happened due to study participation, right? So for example, an NSI item might be, have you experienced any victimization due to participating in this study, right? Whereas PSI item might include, have you, experienced any improvement in health conditions due to study participation? Social impacts in this study were analyzed in two different ways. Per visit, where each visit, follow-up visit constituted a case, and then the per participant data format, where each participant's series of visits, so repeated measures of social impacts, constituted a case. In the per participant data format, responses from the repeated measure of social impacts, right? So social impacts was asked at every follow-up visit. Those repeated measures were separately summed and dichotomized to denote any or no report of NSI or PSI during the trial. We calculated descriptive metrics of the reports of PSIs and NSIs during the trial. All right, time is escaping. So I'm going to share the results of the study. This is a graphical representation of the summary of the reports of NSIs and PSIs. In this raster plot, in this raster format, each column, right, in the vertical lines represent a participant, and each raster line is divided into rows, 6 rows, representing corresponding follow-up visits. And each row also represents, whether NSIs and PSIs have been reported. In terms of color scheme, just to orient you, the greater number of NSIs and PSIs reported, the more saturated the colors are. So red for NSIs and green for PSIs. Yellow cells represent missed study visits, whereas gray represents dates that were past the end of the trial, so the visits were never scheduled. So from this graph, you can see that a substantially higher volume of more saturated green cells are reported, right? So it's quite easy to see. I don't know if you can sort of see the red cells throughout in this NSI raster format, but that's what we're seeing, a substantially higher reports of PSIs. These are the distributions of NSIs and PSIs using the per participant data format. Of the 579 unique participants, nine individuals, just under 2% of the sample, reported any NSI across their follow-up visits, whereas 515 or 89% of the sample reported any PSI, positive social impact, at least once across their follow-up visits. So, consistent with prior research, participants in our study also reported positive social impacts at substantially higher rates than NSIs. And this suggests possibility of ethically conducting HIV prevention research involving MSM and TSM in Kazakhstan, or any high-stigma context for that matter. We believe that the findings of our study were attributed in part to procedures that were involved. And these procedures have informed the next set of recommendations. First is to develop safety plans and risk mitigation strategies tailored to research participants and settings. 2, to systematically assess and consider NSIs and PSIs in determining ethical acceptability. And 3, facilitate partnership and feedback with research participants to ensure researcher accountability. Just want to, this is a list of folks that have made the study possible. I also want to just acknowledge especially our community collaborators and study participants for making the study possible. And these are my colleagues in Kazakhstan. That's it. Thank you.